Hello, my name is Amara Ezeamama. I am a clinical epidemiologist and an assistant professor at Michigan State University. I have the pleasure of studying determinants of functional survival, otherwise known as AIDS-free survival, in populations living with chronic HIV infection for multiple decades at a time on suppressive antiretroviral therapy. Today, I will be speaking specifically on HIV Associated Neurocognitive Disorder in adults living with HIV and the potential for overlap of HIV-related causes of cognitive impairment and non-HIV AIDS causes of impairment, such as Alzheimer's, dementia, and mild cognitive impairment in persons living with HIV. I have nothing to disclose, and my research has been supported by Michigan State University, as well as institutional grants from the Michigan Alzheimer's Disease Research Association, the Research Education Fellowship, and the National Institutes of Health. So let's get started. My goals today are to briefly cover the epidemiology, and that is the aging of HIV-infected population and the prevalence of risk factors for premature cognitive aging in populations living with HIV. To describe dementia or Alzheimer's disease and mild cognitive impairment in older persons without HIV, and use that as a parallel to compare risk factors and the overlap of these in persons living with HIV. Then I'll focus on aging brains with HIV/AIDS, specifically on the overlap of HIV-associated neurocognitive disorder, otherwise known as HAND, and mild cognitive impairment or Alzheimer's dementia in persons without HIV. And then I'll conclude with challenges and opportunities for clinical management of non-HIV causes of cognitive impairment in persons living with HIV. With respect to the epidemiology of HIV, the majority of persons living with HIV in the United States today, based on the 2018 data and consistent with what obtains today, are 50 years and above. Unlike what was the case in the early periods in the HIV pandemic, we're seeing a shift in progressive shifting of HIV to older age ranges. And you can appreciate on this slide the burden of HIV in absolute terms across several age ranges. People that are 50 years and older with HIV are truly living longer. And this is something to be celebrated indeed among those with HIV. As you can see from this survival curve, as you compare the differences in life expectancy for persons with HIV that are shown here across different HIV eras in purple, yellow, and gray curves, relative to those without HIV in the cyan curve, you notice that the survival gap between HIV positive and HIV negative progressively shrank as HIV eras became more recent. And as of the last data from this 2016 study that covered individuals on treatment between 2006 and 2014, we still find that in spite of that improvement in survival expectancy, persons living with HIV still experience net 9 years less years lived compared to those without HIV. And that is even among those without a comorbidity. And so there's, while a lot has been achieved, some gaps remain that are causes for concern in terms of the long-term functional survival of this population. So among the challenges that remain are the fact that comorbid conditions, for example, and these are comorbidities that include hypertension, heart disease, strokes, and also age-related cognitive impairments such as dementia. The number of comorbid conditions at any given age bracket, when you compare HIV positives to HIV negatives, is higher in HIV positive individuals. So, so these individuals experience a net higher level of comorbid conditions at a given age compared to HIV negatives. This leads people to assume and to suggest appropriately based on the data that people living with HIV seem to age faster than those without HIV. The mechanism of this accelerated aging remains unclear. But one thing that has been emerging across data from various sources is that persons who have HIV have comorbid disease profile that is comparable to HIV, to that of HIV negative peers that are more than a decade older. The reasons for this are multifactorial, and some of it remain to be properly elucidated, but there could be possible long-term effects of antiretroviral therapy with multiple decades of treatment, while combination anti-ART itself has been really effective in stabilizing immune function. That immune restoration is not complete, and there is net chronic inflammation in people with HIV that continues despite treatment with antiretrovirals. In addition, there could also be different demographics of persons that are affected by HIV that, independent of HIV itself, puts these individuals at higher risk of developing chronic disease or dying prematurely. And this could be due to structural or behavioral risk factors, as shown here. So next, I'll focus on cognitive problems in HIV across the HIV eras. And then I'll speak about the spectrum of cognitive states in HIV, specifically HAND, and the clinical features of HAND, and give a sense of the risk factors for HAND in persons living with HIV. So in terms of a little history about cognitive problems in HIV, in the pre-ART era, where we had the opportunity to observe natural history of cognitive problems in people living with HIV, about 15% to 20% of persons living with HIV develop the most severe form of neuro-8, and that is the HIV associated dementia due to uncontrolled viral replication. Once HAD developed, prognosis was poor, with median survival time of about 6 months. Fast forward to the combination ART era. This is the era of suppressive HAART or suppressive ART. Prevalent HAD has virtually disappeared, and now it's estimated at 1% to 2%. And the incidence has also dropped by as much as 40 to 50%. However, milder forms of HIV-associated neurocognitive disorder, or HAND, have increased in prevalence in the era of suppressive ART compared to the pre-ART era. So HAND exists as a continuum ranging from cognitively normal or unimpaired to HIV-associated dementia. This 4-point range is distinguished by the existence of impairment in 2 or more domains of cognition, and the presence or absence, including the variations in severity of cognitive problems, as well as the activities, limitations and activities of daily living or interferences in daily functioning. Specifically, based on data from one study that is fairly representative of what is being reported with respect to HAND in HIV, about 53% of HIV-affected individuals are cognitively normal. That means there is no pre-existing cause of cognitive challenges, the delirium is absent, and acquired impairment in 2 or more areas is absent, and of course, there is no impediment in activities of daily living. About 1/3 of HIV-affected individuals live with asymptomatic neurocognitive impairment, and that is a situation where there is impediment in 2 or more cognitive areas without an impact on activities of daily living. About 12% live with mild neurocognitive disorder, and that is characterized by the presence of impairment in 2 or more cognitive areas with mild interferences in activities of daily living. Lastly, about 2% live with marked impediments in 2 or more cognitive areas and marked interferences in activities of daily living. Now, what are the clinical features of HIV-associated neurocognitive disorder? So in terms of the pattern of impairment, the challenges seen in HAND seems to suggest a pattern that, that is consistent with subcortical lesions and includes manifestation of impairments in tasks associated with attention processing, attention or processing speed, working memory, or executive functioning. Behavioral and emotional dysphoria are common, and they may manifest as apathy, depression, anxiety, agitation, mania, and sleep disturbance. In addition, motoric dysfunction is also common, and compared to HIV-negative individuals of same age with mild cognitive impairment, these motoric dysfunctions occur with higher frequency and often earlier in age and could include unsteady gait, poor coordination, and tremor. Unlike mild cognitive impairment or Alzheimer's disease, primary memory disturbances are rare in hand. However, efficiency in learning and retrieval are reduced. And motor symptoms, like I said earlier, are often present at high frequency and earlier in the life course. So here we just want to compare the prevalence of the spectrum of hand in the pre-ART era and in the post-ART era. In spite of the great improvement in HIV disease, the prevalence of any form of hand remains at about 50% in the pre and post-ART era. However, there's been an elaboration of asymptomatic neurocognitive impairment and mild neurocognitive disorder. That is, the less severe forms of hand have elaborated in prevalence in the post-combination ART era compared to the pre-ART era. At the same time, there's a lower incidence of HAD in the post-ART era. A natural question is, why is HAD virtually gone, but milder forms of hand have persisted? To be clear, there are some of this information are things that are still being understood. But just to review the risk factors for cognitive dysfunction in HIV that contribute to hand, chronological age, that is advanced in age, is by far the strongest predictor of hand in HIV. Chronological age combines with other risk factors, some of which are HIV specific, such as combination ART effect, long-term duration of treatment, and potential sequela of long-term treatment, in addition to persistent inflammation that may be due to not incompletely restored immune function and or aging, and as well as chronic disease risk factors that are much more highly prevalent in HIV, and always combining with genetic and lifestyle risk factors that apply to anyone, regardless of HIV status. These several factors combine together to increase the prevalence of hand or cognitive dysfunction in HIV. As I said earlier, while the prevalence of hand has not changed in the contemporary ART era, the relative contribution of HAD, the most severe form of hand, has reduced in time. So as you can see, it is the accumulation of risk factors. HIV positive individuals specifically bear the risk factors associated with HIV status and a higher net burden of health and risk behaviors that promote cognitive advanced accelerated cognitive aging, and the normal risk factors associated with aging. And it is the piling up of these risk factors that breaks the proverbial camel's back, or that breaks the brain. So next, I will highlight the key statistics about Alzheimer's disease prevalence and risk factors among HIV-negative older adults, in hopes that the similarities and differences can be appreciated between what obtains in HIV, and also to underscore the potential for overlap of both aging and HIV-associated cognitive dysfunction in persons that are living for extended periods of time with HIV/AIDS. So dementia is an umbrella term for a range of memory and thinking related problems that are generally serious enough to interfere with daily life. A range of types of dementia are recognized, but the most prevalent is Alzheimer's disease at about 80%. And one thing that is pretty clear is that Alzheimer's disease, while it's strongly age-associated, is not a normal manifestation of aging. The global burden of dementia is rising rapidly, and presently about 6.1 million Americans live with Alzheimer's disease. That number is increasing at a very rapid clip still over the next 4 decades, with that rising to as much as 13.8 million by 2060. So what is already a very high burden of Alzheimer's disease would be further intensified in the years to come as demographic changes supporting longer lives continue to occur. So as we age, we may see some minor changes in cognition and thinking. And these changes are primarily in memory and problem solving. And also there may be some changes in speeded tasks, which reflect more of a motor response problem. These changes are often minor and do not typically affect our day-to-day lives. However, significant changes in thinking, memory, and other brain functions that are noticeable enough to affect daily life is what is called dementia. And that is not a normal part of aging. Like HAND, HIV Associated Neurocognitive Disorder, dementia exists in a spectrum that ranges from cognitively unimpaired to severe dementia. And the various stages of dementia are distinguished from the presence or absence of impairment in 2 or more domains and impairments that result in interferences in activities of daily living. So like HAND, increase in age is a huge risk factor or the strongest risk factor for MCI. This risk that increases with age combines with some other factors that are also present in HIV, such as inflammation, the burden of other chronic diseases such as hypertension, heart disease, and diabetes and others, metabolic disease, and frailty, as well as genetic and lifestyle factors to increase the likelihood of developing mild cognitive impairment. And there's very good evidence that shows that the development of that over a 5-year period, individuals with MCI are elevated risk of developing dementia. So next, we want to highlight key statistics about Alzheimer's disease prevalence and risk factors among persons living with HIV. And the point of this section is to highlight the overlap of cognitive dysfunction of potentially non-HIV cause in persons living with HIV. As we just discussed, people living with HIV are at increased risk of cognitive problems. They tend to have a higher than average number of Alzheimer's disease risk factors. And they're also, by virtue of being HIV positive, at risk for developing HAND. For those who are 50 years and above, currently, most of them are likely to have lived through an era where, depending on when they contracted HIV in the first place, they may have been had periods of no treatment or delayed treatment or suboptimal treatment because the treatments available initially were not as effective. And all of these factors that are related to treatment beyond their control further exacerbates the magnitude of cognitive problems people have across the different HIV eras. So in terms of age-associated HIV cognitive decline, again, age is the strongest predictor of HAND, as well as Alzheimer's disease-related dementia. In persons that are virologically suppressed living with HIV, studies show that HAND is not progressive in 70% of persons living with HIV. And this is a point of distinction from MCI, where the likelihood of progression is relatively higher in MCI compared to HAND. Yet, what we do see is that people living with HIV in their 50s and 60s appear to function cognitively more like persons without HIV in their 70s and 80s. So the combination of aging, while on combination antiretroviral therapy, and other risk factors may result in more than additive and possibly synergistic risk of Alzheimer's disease or mild cognitive impairment in older persons living with HIV. This hypothesis is borne out in a few studies that the hypothesis being that persons living with HIV would be at higher risk of developing non-HIV associated cognitive problems. So in this study, which is a longitudinal study of 347 individuals followed for 9 months, HIV positive individuals who had asymptomatic neurocognitive impairment at enrollment were compared to normal controls. And what they found was that over a 90-month period, the time to display of symptomatic cognitive impairment was much faster for individuals with HIV that were classified as having asymptomatic neurocognitive impairment compared to controls, and that is in the red line. Similarly, another study of HIV positive and HIV negative older individuals compare the rates of mild cognitive impairment among people living with HIV. This is, in this study, they make two kinds of comparison: an overall HIV negative and HIV positive comparison, as well as disaggregation of that same comparison across various age ranges. And what they basically find is that the prevalence rate of MCI among HIV positive individuals is about 3 times overall compared to HIV negative individuals. When this is further disaggregated by age, you see across the age spectrum, HIV positive continue to be at higher risk. However, the high risk, the rate of the disparity in prevalent MCI is much higher among older HIV positive individuals 60 years and above compared to HIV negative adults 60 years and above. So you have what appears to be a more than additive prevalence rate of MCI in the oldest age bracket. Beyond just the prevalence of MCI in HIV positive compared to HIV negative individuals, a recent study followed individuals with HIV that did not meet the criterion for dementia and compared the incidence of dementia in HIV positive individuals compared to HIV negative individuals. And the incidence of dementia means development of a new diagnosis of dementia. And they do this for across the life for individuals between 50 and 80 years of age. And what they found is that at each age interval, so at 60, 70, and 80 years, individuals with HIV have higher incidence rate of dementia compared to HIV negative individuals, starting with a 2% to 1% prevalence at age 60 and ending at a 26 to 14% prevalence by age 80. So to sum things up a little bit in terms of what we've talked about so far, people living with HIV for a variety of reasons that are not fully understood appear to age faster than HIV negative peers. Beyond the HIV-specific risk factors, behavioral risk factors and comorbid chronic disease risk factors that increase the likelihood of developing MCI and Alzheimer's disease in normal aging are more prevalent in people living with HIV compared to their peers without HIV. Even in the era of suppressive antiretroviral therapy, cognitive problems remain a major problem, although effective antiretroviral treatment has lessened the severity of those problems. However, the frequency of less severe forms remains high. Studies also show a higher prevalence and incidence of MCI and AD type diagnosis among individuals living with HIV compared to demographically matched controls. Now I'll just speak to some of the challenges and opportunities for clinical management of non-HIV related causes of cognitive dysfunction in persons with HIV. I'll start by just specifically being clear on why looking at the overlap of asymptomatic neurocognitive impairment, for example, and MCI matters in persons living with HIV. MCI has a very well-established history, and there's existing associated behavioral and clinical management algorithms for treating persons with MCI. At the same time, in HIV, the clinical relevance of the now higher prevalence of asymptomatic neurocognitive impairment is sometimes unclear. And it may overlap with MCI. And frankly, more work needs to be done to understand the relevance of ANI for concrete health and cognitive outcomes in persons with HIV at the present time. But in HIV negative individuals, we do know that mild cognitive impairment is linked with a higher risk of progression to AD within 5 years. On the other hand, ANI and its association with progressive cognitive decline in persons living with HIV is more variable. And so that's a phenomenon of potential distinction in trying to decide what is what, but more work needs to be done to be able to reliably distinguish both. What we do know is that about 25% of persons living with HIV with asymptomatic neurocognitive impairment also meet criteria for MCI. Hence, the failure to consider non-HIV causes of cognitive decline in persons living with HIV could be a missed opportunity. As I alluded to earlier, distinguishing HAND from AD and MCI needs more work. Unlike MCI and AD, there is no single diagnostic biomarker or combination of biomarkers that we know that allows you to diagnose HAND in persons with HIV. HAND in HIV is a diagnosis of exclusion, and it's based on cognitive impairment per neuropsychological testing in multiple domains, with or without the presence of limitations in activities of daily living. The clinician must rule out confounding conditions, whether they are from other central nervous system opportunistic infections, neurosyphilis, substance use, etc. And to just complicate matters a little bit more, asymptomatic neurocognitive impairment in this era of suppressive ART can occur in a variety of patient types, and it's not strongly associated with the markers of immune activation, as was the case in, with HAND in the pre-ART era. Lastly, it is also possible that HAND is being diagnosed at an earlier stage and perhaps more frequently due to rising awareness. All factors that really calls for more rigorous understanding of the various forms of cognitive states in HIV and how that the distinctions that need to be made between HIV-associated neurocognitive dysfunction and dysfunction related to aging, prompted or driven by non-HIV causes. So to conclude, HAND remains a challenge in HIV despite virologic suppression. As a normal agent, the causes of cognitive dysfunction in HIV is multifactorial, with advancing age being the strongest risk factor. HAND risk factors overlap with aging-associated mild cognitive impairment or Alzheimer's disease. And with increasing longevity in persons living with HIV, it is increasingly important to consider the potential for cognitive problems that are not explained by HIV. The failure to consider these non-HIV causes of cognitive decline in this vulnerable population could be a missed intervention opportunity that should be increasingly important in the clinical management of persons living with HIV. These are my key references for this presentation, and thank you.